Hi, it's Kristen here at UT Southwestern Medical Center. Thank you for joining us for our Facebook Live chat with anesthesiologist Dr. Carl No. Dr. No is a pain management specialist here at UT Southwestern who serves as medical director of the Eugene McDermott Center for Pain Management and also directs the Pain Management Fellowship Program. So we're excited to have him. Before we start, don't forget to like and share this conversation as we go through. We want to spread this message as far as we can. And also, you want to write the comments in your Facebook feed. One particular reminder is don't forget that Dr. No cannot comment on specific medical cases because you can't do that outside of a patient-caregiver relationship. But we're happy to talk generally about opioids and pain management. So we'll go ahead and get started. Thanks again for joining us. So Dr. No, it's a pleasure to have you here today.
Thank you.
Should be a good discussion. So the first question that I wanted to start us off with is, what are opioids?
They're a class of drug that are used for analgesic purposes. Some of them are naturally occurring, and some are synthetic.
Okay.
And some are semi-synthetic. So you start with a naturally occurring compound and modify it chemically.
Okay. And so what happens in the brain when somebody takes an opioid? Is it anything different from a different type of medication?
They have different effects. They have effects in your spinal cord and maybe even in your peripheral nervous system and in your brain that can help relieve pain.
Okay. And so, they're obviously in the news a lot, different types of opioids. What happens? You mentioned there's some changes in your brain. Can you be a little bit more specific? What kind of feeling does it give you?
Well, it's probably different for different people.
Okay.
Some people may get sedated from them. Other people may get nauseated in addition to the pain relief effect. Some people get a euphoric feeling.
Okay.
So I think it's variable like a lot of other things in biological systems.
Okay, that makes sense. So we know that we had a conference here this week on campus where there were a number of Health and Human Services representatives, and we had one for physicians. What are the conversations about opioids? What's going on?
Well, a lot of it is related to the opioid epidemic in the country, and a lot of people have died from opioid overdoses, and so the conference was in response to that. Okay. So, as we go along, I think a lot of people are curious, there are many types of opioids. There are many different versions. Are all of them addictive? Probably so.
Okay.
They have different potencies, but they all share similar mechanisms, and so they probably all have some addictive potential.
Okay, that's good to know. So I know that opioids is just one of many pain management options. Tell me a little bit about some of the others that we use here at UT Southwestern.
Well, commonly people take acetaminophen or ibuprofen. Those are over-the-counter analgesics that have been used for a long time. Here at UT Southwestern, we have an interdisciplinary pain management treatment program where we have other disciplines besides medicine. We have psychologists and physical therapists.
Okay.
And so we work as a team to try to offer patients a more holistic approach, rather than just focus on pharmacology only. We use medication, but we try to also use other treatments that can be more effective than medication and have less toxicity and side effects. Okay,
good to know. So we've got a question in from Veronica, and I think we're going to get back to that in a second. So Veronica asks, she says, how do you know if you're allergic to pain medications? It seems like a pretty common question.
Well, usually allergies are manifested by itching or a rash. You might have some wheezing or swelling. Certainly if you have any swelling around your lips or tongue, that's an emergency type situation. But frequently they're limited to an itchy rash,
Okay.
and you might take over-the-counter diphenhydramine or Benadryl to manage that.
And those are reactions that would happen pretty quickly, correct?
Usually they're pretty quick after a dose, but sometimes they are delayed.
Okay. Then how do you tell, let's say you're on a pain medication, how can you tell if, maybe you've gotten a little too, you're addicted to that medication, you've gotten a little too comfortable taking it? Are there signs people should watch for?
Well, I think if you are taking a medicine and the focus becomes the medication rather than the pain relief, then that may be a sign that there's some other factor involved.
Okay.
I think it's always good to ask people around you what they think, because sometimes we don't see ourselves
That's very true.
as accurately as others see us, and it's very important, I think, to have that conversation with the doctor who's prescribing your medication.
Okay, good point there. Really good question, Veronica. So we've got one here from Lori, and this goes back to what we were talking about earlier. She says, what are the best non-medicinal ways to conquer pain?
Well, it depends on the type of pain. If it's an acute pain from an injury, obviously you may need to have it evaluated with x-rays or something like that, but assuming it's a minor injury, then you might want to use ice or heat, and you might want to rest it a little bit. And if you're a competitive athlete, you might want to not be so competitive for a few days to let your body heal.
Right.
And then over-the-counter analgesics are commonly used to manage that sort of pain. For things like tension headache, well, obviously stress management can be very helpful with that. Doing stress management techniques can be very helpful. But it depends on the type of pain. But I think just from a general standpoint, I think some moderate level of exercise is good. There's data showing that can help prevent low back pain.
Okay.
And then trying to have a proper diet and maintain a healthy body weight to avoid putting too much stress on your joints beyond what they were designed to handle. But I think exercise and nutrition are very important things that we need to do a better job with.
Okay. I think we've heard that from every physician we've interviewed. Is it eat better, exercise more?
It might be true.
It might be true. That's excellent. So all right, we've got some more questions coming in here, and this one is interesting, and it does get to the opioid epidemic. It said, this person asks, they say, it seems as though the opioid epidemic is an American problem. Is that true? And if so, why do Americans take more opioids than in other countries?
It's certainly worse in this country. I think Canada, Germany, Australia, and Denmark are a little bit different than some of the other European countries and other industrialized countries. I think it's related to opioid prescribing practices. That's where it started. I think so. It's not limited to the U.S., but it's certainly been worse here. I think in the late 80s or 90s, intractable pain treatment acts were passed that changed laws regarding prescribing these medications. And that happened on the state level, and that's kind of when it started. People felt like pain should be treated with opioids, and there really wasn't data proving that was safe.
Okay. So that's a good question as a follow-up to that. The data. So now you've spent the past couple days looking at the data related to opioids. What is that telling you? Are people prescribing fewer opioids than in years past? Are they looking at other alternatives?
Well, I think the prescribing is kind of leveled off, but it hasn't really gone down as much. Because there are a lot of patients who are on chronic opioid therapy, and so I think it's kind of plateaued. But I think most of the studies on opioids were pretty short term. So people assumed that the data from those short term studies would apply to long term treatment. And we heard some data today about a study that was just completed that showed that patients who were treated with opioids for 1 year, which is really the first long-term study, those patients actually did not improve in function compared to the treatment without opioid, and the pain was actually a little bit worse. And there's an idea that patients may get what's called opioid-induced hyperalgesia, where the opioid actually kind of causes a rebound effect. It can aggravate pain. That may be why that was observed in that study. But it's the first solid data from a long-term study to make us question the rationale for prescribing opioids chronically.
Okay, that's good information for all of us to know. So we've got a question from Lonnie, and Lonnie asks, this is somebody who wants to be a doctor. It says, as a future physician, how would you recommend combating this opioid epidemic?
Well, I think not using opioids as a first line treatment. Try to use other things and use opioids as a rescue drug for breakthrough pain. And use it judiciously, and but use it for cancer type pain, end of life type pain, and for acute pain that doesn't respond to other treatments, and then really limit it in chronic pain to special circumstances.
Okay, so it sounds like it should definitely it's a tool as part of many other options.
It's just one tool. It shouldn't be a first line therapy.
Okay, good question, Lonnie, and best of luck in becoming a doctor. So we've got another question here. Are there resources to help patients learn more about the risks and benefits of opioids? I assume they should talk to their doctor about that.
I think that's true, because that's where the prescription's going to come from. And so I think you have to have a conversation with the doctor about that, and go from there.
Okay, all right, good question. So here's another one. And this is a follow-up to what we were just talking about. And they say, if the use of opioids will be scaled back, should patients expect some level of pain after certain operations and procedures? I'm not sure where that.
Well, after surgery or something like that, patients will still be prescribed opioid.
Okay.
But interestingly, there are several papers out recently about how many pills people take after surgery. It's just a fraction of what we've been prescribing. For example, if we prescribe 60 pills, people take 5 to 10.
Yeah.
Then they leave the rest in their medicine cabinet. So that's part of the problem.
Gotcha.
Most people don't need that many. Now, some people do, but most people don't need as many as we've been prescribing. They don't take them.
So they just stop and they sit in their
They
medicine
stop
cabinet.
on their own. Their pain gets better in 2 days.
Okay.
And as we would hope, but they have all this extra medication.
I have to admit that I've done that before.
We all do.
Put it in your cabinet, close the door, and away you go.
No one wants to throw away something you've paid for.
Yeah. Okay, interesting. So we've got a question in from Laura, and this is interesting. Laura asks, what are ways to treat small fiber neuropathy pain without medications? Are there options there?
Well, the things we talked about with our interdisciplinary program, even though you would think that those things wouldn't work, since it's a neuropathy, it's a specific type of disease. We're human beings, and human beings respond to the treatments that are used, and so it's unpredictable, but it's important to at least look at those things, because that's a difficult pain to treat, even with medication.
Right. So you think that you're saying that exercise could play a role in that one and helping?
Relaxation techniques, the things we talked about, can all be partially effective for that.
Interesting. What about things like yoga? Is that a good one?
Yoga is in new guidelines for back pain.
Really?
It's evidence-based treatment.
Interesting. I'm going to have to get back into yoga. All right, really great question, Ashley. Thanks for asking. So now we've got so this one is, I lost it. I do apologize. This one is from Lori. And Lori asks, and this is going back to opioids again, how do opioids affect your brain in the short term and in the long term? Is that known? Can you tell?
Well, I think in the short term, it has, as far as the analgesic effects, they're effective, but we develop tolerance to them so that they lose their effectiveness over time. Then we increase the dose, and then even with increasing the dose, it still loses its effectiveness. And the problem is we don't develop tolerance to the respiratory depression. So the longer we take them, the more we have to take, and it becomes less effective, but it becomes more dangerous.
Okay. All right, when you get to that, I want to remind everybody, just a reminder that we have about 15, maybe less than 15 minutes now, so it's a great time to keep submitting those questions. Do remember, we've got to keep them general. We don't want to ask very specific questions for Dr. No, put us in the hot seat here. But you were talking about the long term. Is that part of the problem with the epidemic? Is that doses are increasing, people are taking more, and then it's harder to stop taking them?
I think that's certainly a big part of it.
Okay.
But some people are at risk for overdosing with acute pain. So there's no safe duration of treatment.
Okay. So if somebody was to come to the pain management center, let's say they have back pain, what would a visit look like? Who would they interact with?
Well, the first visit would be with a physician. So that would be just have a regular medical evaluation.
Okay.
And then after that, if the patient is interested in the interdisciplinary program, or if they have chronic pain, we might recommend that.
Okay.
And then the patient would decide if they want to choose that treatment plan or not.
Okay. So in that case, I think you were talking about earlier that they might end up having some sort of physical therapy. They might have some of the cognitive behavioral therapy.
Yes.
What does that entail?
It's a form of psychotherapy that's very structured and educational.
Okay.
And so patients learn skills to manage stress and increase their coping skills so they can cope with pain better.
Okay.
And that's done with a psychologist. And so the program is it's 2.5 days a week for 4 weeks. So they see the psychologist for 8 sessions and the physical therapist for 8 sessions. And then there's 8 sessions of a group treatment, kind of an educational group. And so it's about as short as you can have that type of program. The older programs were much more intensive, but we found that most patients can get significant benefit with that type of approach.
Okay, so we've got that makes sense. We've got another question in here, and they're wondering about gender differences. Do opioids and other drugs in that family, do they affect men and women differently?
Well, that's a good question. I think different pain syndromes are more common in women. For example, headaches are more common in women.
Right.
Arthritis, fibromyalgia. That there are a lot of conditions that are just more common. And so I think that places women at higher risk for chronic pain, and then therefore treatment for it, which may include opioids. So there may be some more opioid risk there.
Okay.
But I don't know. It's not known. All the differences are not well defined.
Okay, good question. All right, great question. Thanks for asking that. And what about ages? Are there ages that are more likely to benefit from opioids, or is that again, depending on the situation?
Well, I mean, I think as we age, we probably have less pain, and we also
Really?
well, it's less. I mean, for the same stimulus, we have
Okay.
we report less pain for the same stimulus. Yeah.
Okay.
Thank you for correcting me on that.
Less pain as we age. That doesn't sound right.
But for the same stimulus, but we're more sensitive to medication.
Okay.
So it's a balancing act there.
Okay. So what is that? So as we age, we're less sensitive to pain. Is that what?
I think so.
Understand it.
I think so.
That's interesting. Okay. So then how would it differ, a pain management treatment for somebody with migraines that's 60 versus somebody that's, 25?
Well, for migraine, you would, for medications, you wouldn't use opioid. You'd use other types of drugs to prevent migraine, and you probably require less of a dose.
Okay.
And then maybe the same for drugs to abort a migraine, but you wouldn't use opioid for that.
Okay. So we had a really specific one here, and they're wondering. She says, how do you safeguard your patients taking opioids at home? And this is from Stacy. It's a really good one. So they're at the clinic, they go home. How do you safeguard them? Is there a way?
Well, you have to try to evaluate the risk before you write the prescription in the first place.
Gotcha.
But then once people go home, I mean, they're on their own, but you have to have an opioid agreement where they agree to keep their medicine safe, locked up with their kids around, and to not escalate the dose. So there's you have to have a written agreement to outline the things that you need to do to keep it safe.
So is that different from another prescription? Like if somebody do you have the same sort of agreement for all prescriptions?
No.
Okay. So it's mainly just opioids.
Yes.
Okay. Interesting. All right. Good question, Stacy. I know that's on a lot of people's minds. So here's another one. We've got, this one came through. It says, why are we hearing so much about this in the news? Haven't these drugs been around for a long time? Is the problem growing worse? Sounds like it is.
Yes, I mean, these drugs have been around for a long time. I mean, this epidemic, I think is probably a couple of decades old. And some people think it's peaked. And maybe the prescription opioid part of it has peaked. I hope so. But the opioid epidemic overall, I'm not sure it has peaked yet, because there's
the non-prescriptions.
There's fentanyl showing up in heroin. I mean, there are all kinds of things going on. So it's still scary.
Okay. So as an anesthesiologist, a pain management specialist, what do you recommend for somebody has a doctor prescribes a handful of drugs to somebody. Obviously, doctors do their due diligence, but when somebody's going home with medications and they have questions about them, what should be their first line of, where should they go?
Well, I think you should talk to your physician who prescribed the medicine, and then I think also your pharmacist. I think pharmacists are very happy to help patients with questions like that, and we've kind of stopped taking advantage of their knowledge, at least on the outpatient side.
Okay, so ask your pharmacist. That's another good option there. All right, so we've got 5 minutes left. I know we always have questions that go right up to the last minute, so I'm encouraging everybody to submit those questions now so we can take them. Literally 5 minutes. So I want to follow with Dr. No. You mentioned fentanyl as one of the types of opioids. What are the other ones that are out there that people may or may not know about?
Well, hydrocodone is a very common opioid. Codeine, morphine, oxycodone. Those are commonly prescribed opioids.
So those are the common ones. I mean, those sound like ones that are prescribed somewhat often. I mean, I've been prescribed those before. Are those ones that people should be concerned about when their doctor prescribes them?
Any drug like that is classified as a scheduled drug.
Mm-hmm.
So, for example, a Schedule 1 drug is an illegal drug.
Mm-hmm.
So marijuana is Schedule 1.
Okay.
Morphine Schedule 2.
Mm-hmm.
Hydrocodone is Schedule 2 now. And then Tylenol with codeine is Schedule 4. So they go down to Schedule 5. And then, then you have some other, like cough syrup is probably,
right.
Schedule
down
5.
the bottom.
So it's thought to be less addictive than a Schedule 2 drug, but they're all have some addictive potential, or they wouldn't be a scheduled medication.
Okay, good to know. So as expected, we've got these questions. One came in from Stacy while we were talking about it. She asks, what is your stance on take-home naloxone? Naloxone, thank you.
It's naloxone is a reversal drug. So if someone overdoses on opioids, then the naloxone would reverse that and potentially, save a life.
Okay.
And so it used to be a drug that was only administered in a medical setting. It's the only place you could get it. But now this opioid epidemic has become such a problem that pharmacies are dispensing naloxone. You can get an injection, or they have a nasal spray.
Mm-hmm. Wow.
To try to that a lay person could use to try to rescue someone.
Okay.
That's an important step, and I think there's been a lot of success with it.
Okay, good to know. Good question, Stacy. So I think we've got time for this last question here, and there are a couple there. This comes from Charlene. It says, what needs to happen for the opioids to no longer be considered a crisis? What metrics, if any, need to be met? And in your opinion, how long do you think that's going to take? Are we talking about years, decades?
It's a great question. I think there was a model that was made to predict that the opioid crisis would improve in a couple of years, but it was based on mathematics from infectious disease models.
Okay.
Infectious diseases kind of run their course, and so the mathematics were based on that. I don't know that this epidemic is going to behave that way. Okay. I don't know that anybody does, but I hope it does, because then it would kind of take its course. And I think there is pressure on prescribers to prescribe less, be more judicious about the prescribing. But the thing I worry about is illicit drugs, and because a lot of patients, if they have been prescribed medicine, then all of a sudden they're off of it, then they might be at risk for going to illegal drugs
to try to deal with that pain
and to avoid the withdrawal. And so I don't think anyone knows how long it's going to go on, but it's been building up for a couple of decades.
Yeah. Sorry, we don't have better news, Charlene. I think that sounds like reality. We did, just before we go, had a note. Apparently your clinic staff is watching. They're very excited. We are happy you're all here watching this chat. It's definitely been informative. With that, I think, is there, as we wrap this up, is there, what do you want to tell people that may be experiencing chronic pain about options that are available to them?
Well, I think it's important to do the things we talked about with exercise, diet, those kind of don't smoke, those kind of, which sound repetitious, but I think they're more important than I think we've realized. I think start with your primary care doctor and have your pain evaluated.
Okay.
And then if you need to see a specialist, your primary care doctor can refer you. But I think we see a lot of patients who don't have primary care doctors, and I think you need to have a primary care doctor.
Okay. All right, so start with your primary care doctor.
I think so.
Okay. Well, it has been a pleasure having you, Dr. No.
Thank you.
I want to thank all of our guests for all the great questions today. Thank you very much. As usual, this chat will be available here on Facebook, and it'll also be on our UTSW Med YouTube channel this afternoon. So we hope you enjoy watching it there, and please be sure to share that for all your friends that aren't on Facebook, on YouTube. And one final thing, so Friday we will be live with Justin Parekh talking about organ transplants. So we hope you're able to tune back in. In the meantime, hope you have a wonderful day, and thanks for joining us.